Good evening. I'm Fiona Fleming, the Director of Monitoring, Evaluation and Research at SCI. And this evening myself and my colleague Michelle Clements will be talking about partnerships within monitoring, evaluation and research. And we will just be touching on some of those and not all of those. So bear with us if you're one of our partners and you're not mentioned this evening. There are sort of three themes which we focus on in terms of our monitoring, evaluation and research. And they are monitoring the effectiveness of control programs, developing ways of strengthening control programs, and researching future control and elimination strategies. I'm going to talk about the first part, about monitoring effectiveness of control programs. So as you've already heard this evening, one of the first activities that we partner with our Ministries of Health is mapping, trying to determine who needs treatment, where are people with infection. So we go out, and again, as you've seen this evening, sometimes trying to find where those people are can be quite challenging. So we have school-based surveys that we carry out to determine where people are that are infected and try and identify where there's moderate and high intensities of infection, and stool and urine samples are collected to identify eggs. This information feeds into us producing maps which are then used to determine where treatment should happen at a district or a sub-district level according to WHO treatment guidelines. This is a picture of the NTD program manager in Liberia, and he's the focal person who will use this information to ensure that any money and drugs coming in are targeted to these areas, and treatment is carried out accordingly at the right frequency and to the right target people. On a more global level, this information that we collect for mapping feeds into WHO reports on the distribution of schistosomiasis and keeps information up to date. We also look at the coverage, so who received treatment. In many of our programs, we're focusing our treatment at school level, but is everybody that needs treatment receiving it in the schools, as we can see in this picture in Uganda? Or are there some children, such as this girl in Niger, who don't attend school or are enrolled in school but don't get to go for other reasons? So we carry out coverage surveys which help to validate the reported treatment numbers that come in from the governments. We do this by holding community household-based surveys. And the picture on the right is of an enumerator interviewing a child, a school-aged child, which is normally 5 to 14 years of age, and asking whether they took treatment, and if they didn't take treatment, why they didn't take treatment. These surveys help us to determine within a country what the gender split is in coverage. Are boys and girls receiving the same amount of treatment? Are the same age groups receiving? And this graph from Zanzibar shows that across the two islands in Zanzibar, treatment there's a difference between the treatment in those who attend school and those don't, with those attending school reaching above the WHO minimum threshold of 75% coverage for the treatment of schistosomiasis and soil-transmitted helminths. Again, this data is fed into the Ministries of Health, and they use that to be able to determine what different strategies they might have to use to capture everybody who's in need of treatment. So if the non-attending are not reaching, do we have to change the strategy and reach out to the communities and target them that way? So this information is used by ourselves, but mainly by our partners in country. And again, on the global level, it can feed into bigger platforms such as the annual scorecard, which is overseen by Uniting to Combat for NTDs, in which Wendy will discuss more in her presentation. We also want to know what has been the impact of our treatment. We need to know this at SCI to feed back to our donors, to show them that all their efforts, their money, the drugs that they're giving are making an impact. Are we making people better? Are we getting rid of these worms? A picture of a mating pair of schistosome worms. We also have to be able to carry out these surveys to determine impact. We often have to build capacity with the in-country teams. So this is a picture of a South initiative. Dr. Cabatarani and his colleague Betty are on the right, and they've been training technicians in the Democratic Republic of Congo on how to diagnose both the species of schistosomiasis and the STH. In other ways, we're beginning to build capacity building in data management and analysis, as we've really seen that this is a gap within our partners, and it's something that we're really trying to build on. And all this capacity building will help countries to be more autonomous in terms of evaluating the impact of their own programs. Again, there are challenges in the field when we're carrying out these surveys which measure the infection every year. And this is a picture of a colleague in Ethiopia with a camel taking all the M&E equipment to the Sentinel school that's going to have infection measured in it. So there are randomly selected Sentinel schools within a country. We carry out the first lot of data collection pre-treatment, and then prior to every subsequent round of treatment within the country in the same schools every year. This allows us to see the impact. So this graph from figure from Malawi shows at the school level prevalence of schistosoma hematobium going down in 6 to 8-year-olds over time, with the mean change in black. And again, this data is used for the Ministry of Health programs and partners to know that what they're doing is making an impact, but also to help advocate at the government level that all the, I guess, non-monetary investments that they're putting in are having an impact, and that the health is being improved in children within their country. And ultimately, the goal of all this is to achieve happy and healthy school-aged children and communities. We've also begun looking at ensuring that the resources that are given to SCI and given to the countries are used in the best way to get the best buy for donors. So we look at what is the treatment cost and look at several other value for money indicators. This graph shows the annual cost per person treated for NTDs in Uganda over time, and it shows that with the more people treated and with the experience over time, you're seeing economies of scale and a more cost-effective treatment program. Again, the value for money indicators that we're collecting help to give benchmarks for the country so that they can know where particular activities or inputs there's overspend on them, and they can adjust accordingly. And this data from our countries is feeding into WHO benchmarks for investment targets for schistosomiasis control. Finally, we also look at more qualitative data, and it's something we're starting to strengthen to try and understand why some individuals do not receive treatment. Is it supply side issues? Is it because perhaps transport, the community drug distributors are not getting the drugs to where they need to be? Or is it demand side issues where individuals are not seeing the posters that are advertising that treatment's going to happen, or not understanding or not getting the information about why you should take the treatment and how to prevent infection? So all these components together of monitoring and evaluation are really trying to help us understand who takes the treatment, who doesn't take the treatment, and how we can really improve our programs to make sure that in the last mile of treatment we get to all those vulnerable children that need treatment. I'm now going to pass on to my colleague, Michelle.
Hi, I'm Michelle Clements and I'm the Senior Biostatistician here at SCI, and I'm going to be talking to you a little bit more about the research projects that we're involved in and just give you a little bit of flavour of the different things we have been doing. One of the first things we are doing is developing ways of strengthening control programs. So the control programs we currently have, how do we make these better? And I'm going to show you an example from mapping, coverage and impact surveys, as Fiona has described to you already. So for mapping strategies, we've been doing some work researching alternative mapping strategies, and the question we've been looking to answer here is how many schools should we map per district. So on the one hand, if we don't map enough schools per district, then the estimate that we have of prevalence of schistosomiasis or STH in a particular area will probably not be a true reflection of what's actually out there. And that might mean that we treat children where treatment wasn't necessary underneath WHO guidelines, or even worse, we miss treating whole sections of children that should have been treated. But on the other hand, if we map a large number of schools per district, then that really increases the cost of the mapping surveys and impacts on our cost effectiveness. So to address this question, our previous biostatistician, Sarah Knowles, has been working with people from the London Centre for Neglected Tropical Disease Research and researchers from the University of California, San Francisco, as well as teams from Liberia, Cote d'Ivoire and Malawi, to use the mapping data there to feed into simulations looking at different mapping strategies, and then tying this to the cost component as well. And as you can imagine, the answer to that is dependent on the most optimal thing to do is dependent on a whole host of different factors. But that's been written up into a paper at the moment and will hopefully be published in the near future. So that can help feed into the wider schistose community strategy. In terms of coverage, we have a project in Uganda that's just kicking off at the moment that's in partnership with the Bill and Melinda Gates Foundation as part of their Grand Challenges in Global Health, and also the in-country teams in Uganda. And the question that we're looking to answer there is, do incentives improve treatment coverage in areas that have received treatment for many years? So we're going to be doing an experiment with different schools and different communities receiving different incentives. And the incentives we're looking at is distribution of shoes, distribution of food, and health education and distribution of soap. So that's just beginning to be kicked off at the moment. In terms of the impact analysis, we have a study that has been going with the SCORE consortium for the last 5 years in Mozambique and Niger, and that is also in collaboration with in-country research institutions and in-country ministers of health and program partners. And we're asking which treatment strategies are required to gain and sustain control of schistosomiasis. And in Mozambique, we're looking at the impact of treatment coming through the schools versus treatments coming through the community. And we're also looking at treatment every year and treatment on a less regular basis, such as when treatment holidays occur. And in Niger, we're looking at treatment once per year versus treatment twice per year. And all of these programs are just coming to a finish now, and the data will be coming in the next couple of months, and that's something we're really excited to see the results of when that comes through. So that's kind of a flavour of some of the stuff we've been doing to improve our current control programs. But we also want to be looking towards the future, and what does the future of schistosomiasis control programs look like? So we're also researching future control and elimination strategies, and that's mainly elimination as a public health problem. The definition of elimination is quite a slippery beast. So one project we have is an SCI member of staff who is also doing her PhD with us. It's based in Uganda in collaboration with the Children's Investment Fund Foundation and partners within Uganda. And this is looking to ask, will targeting school-aged children really be sufficient to eliminate schistosomiasis? And one of the first things you have to do on that is try to figure out exactly who has schistosomiasis and how does that work in the different age groups. So here we've got a graph with age along the x-axis and prevalence of schistosomiasis up the y-axis. And this is in 3 different communities. One of these communities is high prevalence of schistosomiasis, so that's in red there. One community is a low prevalence community but is being treated in green there. And the other one is a low untreated community that is in blue there. This is looking at age distribution. So you can see for the high prevalence community that schistosomiasis seems to be highest in the 15 to 16-year-olds and then is lower in the adults. But it's still at quite a substantial level, even though it's lower. And these findings will feed into mathematical models to try and get to the question of, will targeting school-aged children be sufficient to eliminate schistosomiasis? One other thing that we've been looking at the moment is assessing the performance of new diagnostics. So schistosoma mansoni is normally tested by CATO cats, and that involves taking stool samples across 1 day or multiple days, which are then made up into slides and they're examined underneath the microscopes looking for eggs. And I believe there's some microscopes outside so you can have a little try for yourself to see how easy it is. And so this is quite technical, it's difficult, it's time consuming. There's a new test that's come out called CCA, which is a urine test where these cassettes, these plastic cassettes are put into the urine, and then there's coloured bars that develop on each of the tests to determine whether an individual is positive or negative. And that's obviously a lot easier to use, a lot simpler. There's one of our SCI members here examining 5 different tests at once. But one of the issues we have, so you can see here on the left, this is showing a negative result. So this, we're looking at the top bar here. And on the very right, there's a very strongly positive result, where you can see the 2 bars. And then there's kind of stuff in the middle where it's not quite so easy to really tell what's happening there. There seems to be a little bit of colour, but not a very strong amount. And that's what we term a trace result. And there's a lot of debate in the scientific community about what exactly should we be doing with these trace results. And I've just got a little bit of data to show you from a few different countries. So on the left here, first of all, this is prevalence by CATO cats in Côte d'Ivoire, Uganda, Rwanda, and Burundi. You can see prevalence by CATO cats was about 12% in Côte d'Ivoire, 6% in Uganda, and a lot lower in both Rwanda and Burundi. And then those same children were tested using CCA. And if we use CCA with trace as negative, which is in the middle here, we can see that actually the prevalence results didn't really seem to differ that much between the countries. And then when we include traces positive, there was a large number of trace positives in Rwanda and Burundi, and it actually looks like there could be quite high prevalence of schistosomiasis in both of these countries. And we know that CATO cat maybe misses in infection at very low intensities. So at the moment, we're not really sure what's going on here. These could be false positives. These could be very low intensity of infections that just hasn't been picked up by the CATO cats before. And so more research is needed, and it's a bigger piece than just what SCI is looking at, because it then opens questions of how does the WHO do their treatment strategies if these results are replicated across different countries. So it's a really interesting time for kind of diagnostics of schistosomiasis. And a final study that I'm going to show to you tonight is moving towards elimination in Burundi. And asking how can schistosomiasis be eliminated as a public health problem. So we're going to implement an experiment with 3 different arms. The first arm is intensified mass drug administration of the total population, so not just school-aged children, trying to treat all eligible people. And then we're going to have another arm where we add in snail control as well, and that's going to be in collaboration with people at the Natural History Museum. And then finally, we're going to have another arm with intensified MDA, snail control, and water sanitation and hygiene interventions. And for that, we're going to be partnering with in-country groups from UNICEF and the Red Cross in Burundi. And because they're already on the ground in Burundi doing water and sanitation interventions, and so we're partnering with them to try and make the most use of their expertise. So I hope that's given you a little bit of a flavour of some of the projects that we're involved in. Unfortunately, we haven't been able to cover them all tonight. In terms of the acknowledgements, we need to acknowledge all the communities, the health centres, district level and centre level staff who invest and participate in these control programmes. They're such huge control programmes and so many people put so much time and effort into them. All our partners in Sub-Saharan Africa and Yemen, our funding and research partners, and the SCI team, of course, who all work incredibly hard. And I'm just going to leave you with a few pictures of the implementation teams in quite a few of the different countries. And if anybody's got any questions, please feel free to come and catch me later on and we can talk about them. And we'll also be having some on the floor in a minute. Thank you.